Well, I'm Mike Perini, and I'm proud and happy to introduce a friend and colleague, Dr. Eskew, who I've worked with directly in Wyoming, and who I'm pleased to have talking today about advanced directives. And I'll just remind everybody that these sessions are being recorded and they're the property of the ACCP, the American College of Correctional Physicians, and no other use of these is permitted without the permission of the ACCP board. And Dr. Eskew is a lawyer and a doctor. I don't know if I would have the patience to do any more school than I've already done, but I'm proud to be associated with Phil, and happy that he's willing to talk with us on this topic. This is applicable for CME credit, and just request it, and quarterly it will be granted. We don't give out the certificates on a week-to-week basis. We give them out quarterly. I'll remind everybody about the ACCP and our big educational meeting coming up in September 9th to 11th in Salt Lake City. And without further ado, I'll introduce Dr. Eskew, and I've been looking forward to this talk for quite a while. Thank you.
All right. Well, thanks for the kind introduction, Mike. I've enjoyed working with you as well. I've been doing correctional medicine work in various capacities since 2015, all in Wyoming. And I became an attorney right before I went to med school. I did those things back to back because I knew a lot of physicians who were constantly annoyed with the regulatory and legal issues, and I want to be able to answer those questions. And when you do those things, people start asking you those questions even when you don't know the answer. So you start looking them up. And this particular talk is going to involve a lot of geriatric issues, and we're going to dig into some details about advanced directives and capacity, and we'll get into it here. I do have lots of slides, and I have lots of words on these slides. That's probably my legal background just sort of coming in there. I build them as a reference, so we're not going to read every word on every slide. I'm going to move pretty quick, and we're going to have plenty of time for question and answers, and certain cohorts of these are really just here as reference material for you to look at later. So we're going to go over the clinical importance of early advanced directives. Of course, you want to do this early because the longer you wait, you may have that patient may have that stroke, or they may have that change in mental status, and now you can't know what they really want anymore because they can't communicate that to you. Identify different types of dementia and legal implications for how to make decisions when that's happening. We're going to talk about the difficult conversations in the correctional setting and what that can look like. And we're going to look at state law variants from one advanced directive option to another. There are different forms out there that different states promote, and they go by different names. And that was the reason for the kind of what I hope was a catchy title. You've got these POLSTs, and you've got MOSTs and MOLSTs, and they all mean similar things. And if you start putting them side by side, you'll see that the variance is subtle from one state to the next. And we'll get over how and when to use those. And I think there's a lot of confusion there, including what I've seen here. So it's not unique to one state or another. So there's many different ways to go about advanced directives. And so I've got some lists there for you, and we'll get into that more later. First off, if you're looking at your geriatric patient population and you're talking about mental status, the first thing you want to look at is polypharmacy, because there's an awful lot of that going on. If the patient's on 5 or more medications, there's going to be a decent chance that there's polypharm that you got to deal with. And that's a third of our patients who are age 60 or above. Pill packing systems can increase adherence, and when we KOP meds, they're not getting more than a month's supply at a time. So that makes tracking these a little bit easier in the correctional setting than you would on the outside. And there are a variety of tools you can use to try to figure out if you have a polypharm problem, or if there's a certain medication you simply shouldn't use in that elderly population. Come up with your own process and make sure you stick to it. I've found that pretty much every EMR I've ever used, the interaction checker is disappointing and not reliable, and it's not going to flag things on the beers list, for example. So I don't rely a lot on that. I have my own list that I run through. When you're visiting with the patient, have them bring their medications with you, and you'll figure out if they're taking them the way they should pretty quickly. Okay, and Why should you run your own interaction search? There's a Senator trial in case you've thought you were having different EMR experiences than me. I think mine is the norm, where the regular EMR checkers just aren't any good. And you've got plenty of free interaction checkers you can use. My favorite is Medscape. If I'm doing Hep C prescribing, then I use University of Liverpool for good interaction reports there. And before you renew something, you got to take a close look at the entire list of medications. Some of the more common ones that people have to be careful about are listed there. I think it's always unfortunate if you see somebody who's getting a patient's being treated for iron deficiency and you don't know why. Could be colon cancer, could be any number of things that are sort of lurking there. So I'm careful anytime I'm renewing these medications, because I want to know if they have any sort of malignant source or any H. pylori source, or if I'm worsening some sort of chronic kidney disease or hypertension with an NSAID. And this is just an example with iron that you all have probably seen before. Iron overload can cause some liver disease. You might be covering up a cancer. You might be covering up the fact that NSAIDs are being overused, and maybe there's a gastric ulcer you didn't know about. So don't just renew things quickly there. With omeprazole, similar idea. Don't miss H. pylori. Don't miss an ulcer. And what about meloxicam? Lots of reasons to be careful about your NSAIDs. The VL Medicine blog has an excellent write-up on NSAIDs that I've linked there. And we got to be careful about chronically renewing those, especially as patients get older, because there's a decent chance they're going to have some kidney disease or some heart disease. It's going to counteract the beneficial effect of their aspirin if they take it within 2 hours of taking the aspirin. It's going to increase their blood pressure. It's going to increase sodium retention. It's going to interfere with most of their hypertensive medications except their amlodipine. So lots of reasons to watch that. Different beers list categories. And I've got some references in here there for that one later. Some of these are not open access, but the ones that are, I've got them listed. So there's an Institute for Safe Medication Practices. They have their own high alert medications, and this is more of an urgent care mentality with this particular list. And I put some in red that are ones that I find myself prescribing with some regularity. The others I don't see so much. And then we've got the Institute for Safe Medication Practices, and they've got the chronic listing as well. And again, I've got those listed in red. This is meant to be a reference. Certain things that if you're using in your geriatric population, you want to think twice. I think we're already in the habit of doing that with warfarin, where we calculate a CHADS 2 VAS score and a HAS blood score, and with rivaroxaban. But maybe we're not doing that quite as much with some of the others on this list, where the risk benefit is not so easily calculated. Then they've also got a long-term care setting list, and there's a lot of crossover here. So again, that's there for your reference. The Beers criteria, unfortunately, is not open access, even though that's the one that's cited the most. I was able to find a few links that offer you some comparisons, and I do have those there. And if we have extra time and people want to walk through that, then we can do that. But again, this is meant to be a reference. In general, some of the high points: try and choose an SSRI that has a shorter half-life. That way, if you do have a complication, it's easier to deal with and to stop. Watch for TCAs with active metabolites. Try and choose the ones without active metabolites. We're already in the habit, at least in Wyoming, of using nortriptyline, and we rarely use amitriptyline. That's a non-formulary for us. Try to avoid your first-generation antihistamines. The fall risk increases with those, the diphenhydramine, the hydroxyzine. Doxazis and clonidine are both to be avoided as well. Of course, clonidine, you get a lot of rebound if you're trying to do that for any kind of hypertension purposes. Oftentimes I'll see psychiatry use a low dose of it in the evening. And you got to be worried about a little bit of diversion there in the correctional medicine setting. If you weren't worried about diversion, if you're trying to treat hypertension, especially outside of correctional medicine, then a clonidine patch that you put on once a week is probably your most stable way to use it. But it's just not something we can routinely use in our setting. Okay. And then we've got stop criteria is another one you can point to, and I've got a link there. Just they list a lot of medications that they routinely stop in patients once they're above age 65, and they got them cohorted by different organ system. And here are some of the high points of those reviews. Aspirin, if you don't have any history of CAD. that as you all probably followed that in the literature, there were discussions about aspirin decreasing your risk of colon cancer, and then they said, oh wait, maybe not. Maybe it decreases your risk of a heart attack. Maybe not as much for primary prevention as we thought. Secondary prevention, it's excellent. But if you had somebody who was at risk and started on this because they were between age 40 and 60 and their ACC risk score was elevated, once they hit 60, 65, if you're following the stop criteria group, maybe you're rethinking whether or not you're still taking that for primary prevention at that point. Calcium channel blockers can lead to some constipation. I didn't know that before I did this review. So you can see, again, this is an interesting list to kind of walk through when you've got some free time later, when you're debating whether or not to sort of tinker with your geriatric medications. Your START tool is another one to look at, similar to the STOP. And these ones, it's the reverse, of course. They're trying to start, more likely to start these medications in a patient over 65 because they're especially safe. So that list wasn't quite as long, but there are a few there in ways that they're considered. There's also a medication assessment index. So this is a 10-question tool you can use to look at risk benefits of different medications, drug-drug interactions, drug-disease state interactions. I've not used this one. MedStopper is another one. So you can input patient's list of medications and it helps you look at that entire list. This is more of a computer algorithm driven. It's sort of a, shall we say, a dumbed down approach to this. And if you want to see what a computer algorithm would tell you to do, then you've got a way that you can do that. And that one's open access also. Okay. And then there are general classes of drugs that you'll see across multiple lists. A lot of these, I think, we're already not using too much in correctional medicine because they're controlled and can be diverted and abused, especially the benzodiazepines and your Z drugs like Zolpidem that are meant for insomnia. And they may or may not increase Alzheimer's risk, which is interesting. Okay, so we've kind of run through some of the things I wanted to hit quicker, and I'll slow down a little bit now. With dementia screenings, you got several different ways you can do that. A lot of times patients will bring this up. When people come to our facility, they get an IQ test. They've spoken with several nurses before they ever get to me. So the patient or somebody else tends to say, hey, we're wondering about this guy's memory. And then we start doing screenings. My favorite, because it's open access and easy to use, is the St. Louis dementia screening, which we'll come to in a minute. A lot of people are using mini mental status exams here, and that's really not meant for dementia screening. That's meant to look for delirium. That's more of a hospitalist approach to, are you too delirious to answer our questions in the short term, but that's not the best way to screen for dementia. And it's also copyrighted. So if you're using it, you're supposed to pay them a fee to use that. St. Louis dementia screening is open access and it's meant for dementia specifically. You want to make sure there's not some sort of psychiatric condition that's getting in the way. Certainly, if you work in the jail setting, you'll see lots of patients in various states of withdrawal, and that's not when you do a dementia screening. If you think there could be an underlying medical condition playing a role, then make sure you rule those out. So you could do a thyroid stimulating hormone level. That's a reasonable thing to check. It's easy to do. The MMA stands for methylmalonic acid level, because B12 deficiency could do this. And that's a more specific way to look for B12 deficiency than a vitamin B12 level. CBC could look for any anemia, CMP, of course, to look for electrolyte issues, and your brain MRI is something that's warranted many times. And then dementia can break down various ways. You've got half of patients are going to have Alzheimer's dementia, 20% will have vascular disease, another 20% have a mix, and 10% have other, where you may not fully figure out exactly what kind of dementia it is. And the way you know this, you can get a hint from the MRI, depending on what you see on the brain MRI. Maybe one part of the brain is affected more than another. Oftentimes you have this vague global atrophy, and that doesn't really pinpoint things. And the only way you can try to pinpoint is based on the patient's symptoms. If their personality is suddenly way different, maybe you've got an interesting case where, it's like the TV show Breaking Bad or something, where somebody had one personality for a long time, and then all of a sudden their personality is different, and it was frontotemporal dementia that put them in prison because it changed what they did. You could have something interesting like that. So you never know when you start to look into this. It could be infectious disease. If it's prions, the patient's not going to be alive very long, and that's quite rare, fortunately. Tertiary syphilis is certainly possible, and you got to do an RPR and do your screenings there. So I already mentioned the St. Louis dementia screening. There's the link at the bottom of this slide if you want to do that one. That's my favorite. And it's got lots of different things on there. You can have a patient do a basic clock drawing test. You can have them do 3-item recall 1 minute later, word list generation, name as many animals as you can in 20 seconds a minute, whatever protocol you're using. And that's all in the St. Louis Dementia, but if you want to use your own protocols, you can. Make sure you rule out the organic sources that we talked about on the prior slide. I've got them listed again here. Okay, so what can we do about Alzheimer's? Well, there aren't any good Yeah.
So I just want to jump in and say that the next speaker in 2 weeks is going to be Joseph Penn about mental illness being physical illness disguising as mental illness, and delirium in particular he'd be covering. And so I'm just going to want to throw a plug in for Joseph. Joseph is one of the best speakers in corrections as far as I'm concerned. Almost as good as you are, Phil, but you know. Anyway, thanks for letting me jump in there. Appreciate you so far. And I failed to mention that Dr. Eskew did say that if you want to jump in with a question or a comment, he's open to that. So
yeah, feel free to do that anytime.
Yeah, and I've muted everybody just to, essentially so that there's no background noise is all. So feel free.
Okay. So with Alzheimer's, unfortunately, there aren't any good treatments right now. There were debates about a new medication potentially getting FDA approval, and ultimately that didn't happen. Or I guess Medicare didn't approve it because it wasn't effective enough. So not much we can point to if that's the diagnosis. But you do want to, engage in some preventive strategies if you can, and it's important to tell the patient these things. Maintain a wide circle of friends. Keep an active lifestyle. Try to control your blood pressure, because if you have high blood pressure, you may have these sequential insults to the brain where you're having gradual worsening ischemic disease and a stair-step pattern that's going to worsen your overall dementia and brain function. So there are some basic things you can try to slow the process, but no pill for it right now, unfortunately. So we'll come back to what to do as you find these find dementia over time, but we'll also talk briefly about screening modifications and how these happen. So I'll be interested to see what Dr. Kozarowski thinks about this at some point, but we do have USPSTF guidelines that we follow for a variety of cancer screenings, and those things do change with age. And a lot of this stuff was driven by excellent talks that I've heard from Dr. Kozarowski over the years. So prostate cancer, most men, I should say, die with it rather than of it. If you listen to Dr. Kozarowski talk, he'll tell you 50% of men over the age of 50 have some sort of prostate cancer cells in their system. And most of the time, that's not going to be what takes them out. If they make it to 80, it's 80%. If they make it to 90, it's 90%. And it's almost never going to make sense to do a PSA test on a patient greater than 75 plus, unless you already had a reason to track that beforehand. If they've got less than 10 years of life expectancy, then similarly, it doesn't make sense to start doing this screening. Even when you're having PSA relapses on patients who are post-prostatectomy, you're still talking 8 years away from metastatic disease, even with the PSA relapse on average. So that's interesting to note, just how slow it usually goes. And of course, you can have your patients where they have the reverse and they've got some aggressive prostate cancer in their 50s or 40s, but the majority are not going to be in that mindset. And if you're talking about the geriatric population, they've already made it through that, shall we say, more dangerous potential period. What about colorectal cancer screening? What happens there? Well, of course, they lowered the age from 50 to 45 now, where you have a level B recommendation where insurance still covers it. But they didn't change the upper level. So at 76 or above, it's still sort of a conversation between you and the patient. What's their life expectancy look like? What are their other comorbid diseases? And what's their, family history probably doesn't play a role as much at that point. So it's just whether or not they want to continue screening is between you and them. We follow USPSTF guidelines here, and typically for patients at low risk, we're doing stool hemoccult cards annually, which fit within the USPSTF guideline. So if they want to keep doing those are easy to continue. Breast cancer screening, unfortunately, has some similarities with prostate cancer. For all of our efforts at screening women for breast cancer to try to have women live longer, they don't necessarily live longer because they did the screening, which is a bit of a head scratcher. But we do follow USPSTF guidelines, and this slide is already outdated. They just changed this. So USPSTF used to differ from ACOG, and now they both recommend starting breast cancer screening at age 40. The main difference is it's every other year for USPSTF, and it's every year if you're following the ACOG guideline. But again, notice what I've highlighted here. The point of our conversation today is that once women are 75 or older, you may discontinue the screening depending on what their comorbids look like and how long they think they will be around. Lung cancer screening for smokers who have smoked 15 years, or excuse me, 20 pack years or more. You want to do this assuming they have done it for that length of time and have quit within the past 15 years or are still smoking. So this is another guideline that I'm pointing out. The past two, we stopped at 75. Potentially this one, you continue until 80, unless you think they're not a good surgical candidate. We've had a few positives where we have caught early lung cancers. We've been doing this for the past 2 or 3 years since the new guideline came out. And fortunately for us and our patients, they were good surgical candidates and have done well so far. Okay, cervical cancer screening. You got the guideline there. We're not going to walk through the whole thing, but you do that until the patient's 65, and then usually you're able to discontinue screening at that point. What about these other cancers? Skin cancer, anal cancer, bladder cancer, esophageal cancer. USPSTF hasn't really taken positions on these things. Skin cancer is easy to screen. Patients usually point out their skin abnormalities. I try to make it a habit to look at the patient's back because they can't see that area. Anal cancer is maybe the best reason to do a rectal exam now, better than prostate cancer, which has always been the main reason we did those screenings. But that's another thing Dr. Kozarowski pointed out to me, and one that I can say I have noticed as well. I've found more anal cancers on digital rectal exam than I have prostate cancers. Bladder cancer, if they had a heavy smoking history, I think it's worth doing a urinalysis every now and then because it's so easy to do. I did some reading here, and USPSTF, I guess, just hasn't found that worthwhile, even though it's dirt cheap. So for whatever reason, that's not a common screening. Esophageal cancer, not a good way to screen for it. But if you look at the guidelines overseas, a lot of the population is screened for H. pylori, even when they're totally asymptomatic for malignancy purposes. So something we might eventually do here in the US. So I have a pretty low threshold for looking for H. pylori for anybody with dyspepsia on chronic PPIs. Okay. And then the rest of that's there for your reference. I'll keep going so we don't run out of time here. And then this is your differences in cancer diagnoses year over year, male versus female. And if you compare that listing to what people actually die of, they don't really match. So lung cancer will kill you, and it'll kill you pretty quickly, but it's not the most common diagnosis, fortunately. That's breast and prostate, which most people die of rather than with. And then you've got colon cancer, which unfortunately is still killing an awful lot of people. And that's probably the most important cancer screening we do in terms of adding years to somebody's life. Pancreas kills people, but we haven't found a good way to screen for it.
Phil, I was going to just comment to give you, to give the physicians a simple test for the oral cancer. If you see a lesion, just ask if the patient is aware. If the patient is not aware, have a biopsy. Use a rule of 6-7 days. If they say it's been hurting for 7 days and it's not getting any better, if their mouth feels rough, you know, there are certain growth that comes and it only makes the tongue feels rough. And it's been there for 6-7 days and it's not getting any better, have a biopsy. I usually use the rule of 6.
Okay.
666, I call it. And not to be superstitious, but the rule of 6 help you determine if that is happening. Okay.
Thank you. Yeah, I agree. That's a good approach. We've had a few oral cancers here, and that was what a talk Dr. Kozarowski gave 2 weeks ago was really good. He pointed out that if it's HPV related, the outcomes are you can treat it pretty well, and if it's not, then good luck. It's going to be a hard run. Okay. In terms of fall risk, so moving past the malignancy things, and what about the patient's fall risk? This is unfortunately subjective, but if you just ask most physicians, is this patient at fall risk? They do a pretty good job of just telling you, and that's us doing what anybody does. We watch the patient walk up and down the hallway. We look at their chronic conditions and their medications and figure out how much they're complaining of lightheadedness and how weak they are. And we make a pretty good assessment, apparently, even without having a formal tool to do it. And what would you ask? Well, you'd ask the patient how many falls they've had before, whether or not they're using a cane or some other kind of support, get an idea what their muscle mass is, and go from there. You can have the patient do a get up and go test. That's pretty good if you're looking for Parkinson's. You're measuring how quickly they can stand up and walk across the room and then sit back down, and gives you a good idea of what their baseline is. You have them rise from a hardback chair, walk 10 feet, turn around and sit back down. Okay. And of course, if you're used to trying to get things approved in a utilization management process, you probably reference these activities of daily living quite often. And these are important in any patient who's losing a variety of, I guess, capacity for any reason, be it dementia or something orthopedic in nature. But we certainly track these for all of our patients with dementia over time and make sure they have the assistance that they need. Okay, and now into the good stuff, shall we say, the advanced directive piece. This is a hard conversation. And sometimes it's easiest, it just depends on the patient's personality. Sometimes it's easiest to jump right in. And a lot of people don't like to think about their own mortality and the fact that we're all going to die sometime. But sometimes I'll just say, how do you think it's going to happen for you? How did it happen for your siblings or your parents or people in your family in general? Did they die of heart disease? Did they die of cancer? Did they have time to discuss it, or was it sudden? And we try to have that conversation up front and as early as possible. So what do you think it will look like? And what would it be for, a good way to go? A lot of people used to say, well, I want to go in my sleep the way my grandfather did. And a lot of times I joke with patients that may mean they had undiagnosed sleep apnea, because that's one of the most common ways to go in your sleep. But figure out what that means to your patient, and figure out which friends or family they want to be involved and notified of their progress along the way. So you want to put this down in writing for obvious reasons, and we'll discuss several different ways to do that. So you can have what we call a voluntary advanced care planning visit, or work this into a wellness visit, or however you want to phrase it. On the Medicare side, this is the term that they use. And the intention of that visit is to specifically have this advanced directive conversation. The irony is, in many states, you can't complete all the paperwork for them there, even if you wanted to, which we'll get into that in a minute. Many of these terms are confused because you'll see different phrases in different states, but they're all in this broad category of advanced directives, saying or ideally writing down what you want to happen in advance. And you can do that with a living will. You can do it with different instruction directives. You can do it with things that are modified DNRs, which are basically your post and your MULST, where they're listing these orders in advance. And these different methods of doing it have different levels of complication and also have different levels of legal authority, which we'll get into. So the first example that a lot of people have heard of is a living will. And that's where the patient writes down in advance what they want done. And if they guess correctly, or if they have a lot of detail and they say all these things in advance, great. You could follow that to the letter and never have to go beyond the four walls of the document, as long as they've thought of everything. But it's pretty rare that people actually manage to think of everything. So if your state has a directory, you'd want to file this in the directory so that if the patient leaves your facility, goes to a hospital, we've all seen paperwork get lost, but if it's in that state directory, then they can look it up, even if it was buried in 100 pages, sitting on top of the gurney that was taking the patient to the hospital on an emergent basis. And this is going to apply even if the attending physician determines that the patient lacks capacity, which we'll get into in a little bit. It's going to say whether the patient may or shall withhold life-prolonging measures, and it's going to specify some of those. If they designate an agent, which they should, a healthcare proxy, if you will, then that person cannot override this document. Now, there are ways they can write it, that they can write their way around that. We can do lots of things with private contracts, but The default is, in most states, that if they've specified something in a living will, if they say, cut and dry, I do not want to be intubated, and then something happens, and that's the next step in the management of this patient from a healthcare standpoint, and they call the long lost daughter or son who hasn't talked to this person in 5 years, and they say, do everything, I need to talk to my parent one more time. Then if the parent had already specified in writing on the living will, don't do that, then it doesn't matter that the healthcare proxy is now trying to overrule it. That particular hypothetical was already addressed on paper and they can't override it. If the patient has capacity, then they can change this document anytime they want. They can fill this out on Monday. Maybe they have an argument with their son on Tuesday, and then they come back into the clinic on Wednesday and say, all right, now I've decided I don't want to be intubated and I don't want my son to be my proxy anymore. I want my daughter to be my proxy. Fine. They can update this as often as they like. The exception would be if they no longer have capacity. So they fill out the document on Monday. On Tuesday, they have a stroke and they're speaking gibberish for a while. And then even when they're starting to speak words to you again, it's not making any sense. And they bring up the will and what they're saying doesn't make sense, then they haven't regained capacity to actually change the document. For this to be valid, it usually needs to be signed by 2 witnesses, no family, and you need to have a disinterested notary for the most part. So that'll vary by state, so you got to look that up, and that's where it can get frustrating if you don't have those groups available at your office to actually get the document put in place. A routine power of attorney can be filled out for pretty much anything. I could say to Dr. Perini, I'm going to move to Hawaii and I'm going to move there in 3 months. And I know I'm going to need a car and I don't want to have to look around for a car. And I trust your card buying judgment. I know you're really good at buying cars. So I'm going to sign a power of attorney for you to purchase a car up to $10,000, whatever it is, on my behalf. And I'm awake and talking and I have capacity and I've signed that over to you. It only lasts as long as I have capacity. So if I get hit by a bus on the way home and I'm in a coma, and unbeknownst to Dr. Perini, I'm in a coma and I can't even drive a car right now, and he's out there ready to buy a car on my behalf, he's ultimately not going to be able to do that because it was a regular power of attorney. And he's trying to get that done tomorrow, and I no longer have capacity. I lost it in the interim. That's why in healthcare, we sign a durable power of attorney, because it's supposed to work when you lose the capacity. That's when it's most important. It's not when you're awake and thinking and you can make these judgments on your own. So that's why we call it durable. And a lot of places that they found that term confusing, so they just started calling it a healthcare power of attorney, but you'll still see it by both names. I've got an example there out of South Carolina. And ideally, you're designating, you have to designate one agent. Ideally, you designate multiple agents in succession, not as a group. You certainly don't want to designate 2 people and then have them voting on what could happen, and you got some split vote on your hands. So if you have 3 kids, you've got to pick a favorite, even if you don't want to, so to speak. You've got to name a number 1, a number 2, and a number 3. And all your medical records, unless you specify otherwise, are going to become available to your agent so that they can try to make the decision that you would make. That's their default job, unless you specify something else, which would be kind of unusual. So you have conversations with them about what your goals of care are, and you try to put these things in writing, but you can't predict everything. And that's when this person has to make those decisions for the patient for you. And they can do things that might surprise you. They can have a patient get discharged from a hospital AMA if they want. They're basically in the patient's shoes, so they can do those things. And you can see legal disputes happening on this for obvious reasons. And every once in a while, they make the news. We see patients who specify do everything, and they're on a ventilator for 3 months, and there's no timeline for how they would come off that ventilator, and people think it's futile. And maybe you've got one family member who wants to stay on it, another who doesn't, and ultimately there's a judge who's deciding whether or not, if and when to pull the plug. And whoever you give this authority to does have the power to litigate on your behalf. So what if you didn't do those things? Those were the legally robust examples, shall we say. What if you were doing something simpler? You can do a post or a most, depending on what state you're in. There's a post example here from Pennsylvania. And if you pull up those PDFs, you'll see that they're usually 2 pages front and back, or 1 page front and back, I should say. And they've got a bunch of check boxes and then a few places you can narrate, but it's not very fancy. And it's designed to cover the most common and obvious things. Do you want CPR or not? Do you want to be intubated or not? Do you want IV fluids for hydration? Do you want comfort versus limited intervention and full intervention? And sometimes they describe what that means in detail that's helpful. Other times they leave it kind of vague, and that annoys me. Do you want antibiotics? And who do you want to be getting updates about your care? If you notice the bottom or the back of this form, wherever they put it, there's often not a place for any notary to sign it. And the witnesses can be a physician and a nurse, which you often can't have for the more legally enforceable full advance directive that we just went over a minute ago. So you can imagine a hypothetical where you've got somebody who signed the legally enforceable advance directive maybe 6 months ago. Maybe they did that in jail or another facility, and then they transfer to your facility. And then you hand them this post and say, hey, we want to make sure we do your, we follow your wishes appropriately. And in the interim, they've had a change of heart, or maybe they just forget what they wrote before. And now they put down information on a post that doesn't agree with their original advance directive. So if a judge sees that, one document's more recent, but it's not notarized. And it's not signed by fully disinterested parties, arguably. So that's the last thing you want to have happen. So what I try to do is, if they've done any prior advance directive, I want my hands on that. And if we're going to fill out a post, I want to make sure the 2 documents agree. Because DOC often wants post because they like having something quick like this. The nurses like having something quick like this in uniform, just like hospitals. For a long time, all they wanted to know was, are you DNR or not? Which of course is an oversimplification. Because if you wanted to mess with people as a physician, you could say, oh, I'm a partial code. You can use epinephrine, but none of the other stuff. You could specify whatever you want and drive everybody nuts. But the point is, make sure this, if they're updating these things, if they're updating post to post, that's no big deal. You cross out the old one, you put in the new one, and you date it. But if there's some other agreement here, some more enforceable advance directive in the form of a living will or a durable power of attorney, you want to get those documents and make sure that if they need to be updated, they're updated as well. And some states, instead of a most, they have instead of a post, they have a most or a most. Here's an example from Kentucky. And we've got the same kind of problems that I just outlined on the last slide. And then the most basic form of any of this, of course, is your very simple DNR orders. Do we code you or do we not? And if that's all you're doing right now, I think you're leaving an awful lot of care to chance, and that's not the best way to do this. But what if a patient says, hey, I don't want anything done. I'm doing life in here and I don't want to be in here any longer than I have to. Then they can certainly express that preference. In our facility, those wishes are generally honored. The exceptions would be if they're assaulted by someone else, or if there was an attempted suicide, then we're going to try and bring them back regardless. And you do have some states that do have medical aid in dying laws. And I don't claim any expertise here. I don't routinely see patients in any of these states right now. But if anybody wants to pipe up on that, they certainly can. There have been some studies that try to look at whether or not this extended to patients in the incarcerated setting, and I've really not seen much literature on it. And if I had a law student who was coming to me saying, what should I write a paper on? I think this would be a good one.
Mm-hmm. Yeah, and in Oregon, it was not allowed in the corrections setting. And everybody else had the right for assisted suicide, but not incarcerated. So it never came up.
Okay. Did anybody try to litigate it?
I don't know the answer to that. I wasn't a party to it. If they.
Mm-hmm.
Well, in Rhode Island, when I happened to be medical director there for a little while, They had first of all, an inmate became a ward of the state. And they had a rule that you could not have advanced directives at all. And
Wow.
being an old hospice doc, I thought, whoa, this is kind of crazy. It can't be true. So I went to an ethics meeting at the Rhode Island Hospital and spoke to other people, and that got changed. But their argument was that it's an interesting argument that if someone wrote DNR and then tried to hang himself, that would prevent somebody from trying to resuscitate him. And they said, well, you can't do that. That's silly.
Yeah.
So,
And
I think I don't want to babble on, but that really was a shocking revelation and it did get turned around.
Yeah, I'm glad you fixed that. That's yeah, people are letting the exception swallow the rule for sure in that hypothetical. The other place I'd say outside of corrections where you see it, you could have a hospitalized, I mean, places I've worked, you all can tell me if you've seen different experiences, but if you had a patient who was DNR for whatever reason, and then elected to have some sort of elective surgery or palliative surgery, or maybe they just wanted a hernia repaired, whatever it was, if they coded while they're on that operating table, anesthesia is going to, do everything they can to bring them back. They're not going to watch them go because they had DNR on their chart. So there are a variety of hypotheticals in medicine where we tell patients up front, we're not honoring the DNR for that particular circumstance.
So I know that the question came up in Philly at one point where somebody who was in the legal department wanted to make it against the rules to sign advanced directives or like that. And I know that the intent was, and that's a question that I have for you during this talk. The intent was that there's something ethically difficult about me who perhaps could be construed as having a vested interest in this patient's death. I don't, but I could have. Certainly my bosses might if it was somebody costing them a lot of money.
Sure.
And in the incarcerated setting, what are the ethics of these directives when they're coming from, when the suggestion for advanced directives or for a post is coming from us? So as the medical provider, and that I think was the biggest question, that the lawyer was raising it as a rights issue, and then I just raised it right back as a rights issue to be able to say what you want.
Right.
And
I think
and they accepted that second argument.
So I agree with. I'm glad you won the argument, and the answer to their hypothetical to you is that we don't start with a most or a post. We start with a living will and a durable power of attorney. We do the real advanced directive because if you look at the bottom of those forms, they are signed by disinterested parties and they're notarized. So it's not my signature at the bottom of that. It's not a nurse. It's probably a DOC employee or maybe even somebody who's sort of come into the facility to assist them. Most people here do have their own attorney, so they could even have their criminal attorney sign it or somebody else sign it. But that's part of the reason it's preferred to do it that way, is because they've had some because this isn't purely a medical issue, obviously. It's a legal issue, and they've had some sort of counsel with completing it the right way with a genuinely disinterested party, shall we say. So here's an example for so we looked at this listing here, and this is the Colorado End of Life Options Act, and I just put it up here as an example. The patient has a right to request medical aid in dying, and their individual physician, if they've determined that the patient has a terminal illness with a prognosis of 6 months or less, and that the patient has mental capacity. So they can't have dementia and be non-responsive and you think they're going to die in 5 months. That doesn't work. They've got to have full capacity and they got to be 6 months or less. And then the individual has to voluntarily express this wish to receive the medication. And then the right to request medical aid in dying does not exist because of their age or disability per se. It's these above things. So that's what Colorado's law looks like. I don't have the stat in front of me, but I recall hearing a news story about this some time ago. In whatever particular state they looked at, most of the prescriptions that were placed were filled, but not actually taken, which is interesting. So a lot of patients who get this prescription They like having it on the dresser, but they don't actually take it. So legal capacity versus competency. I hate that I have to have this slide. I have studied and studied this, and it stays confusing. These terms are mixed up all over the place. And I've got some examples later in this presentation, including in some legal documents, quite frankly. So it's no surprise that we all confound the two all the time. Iowa, I think, had my favorite state explanation, and I've got that link there above and at the bottom of the slide deck. The competency is supposed to be a legal determination made by a judge. As a physician, it's not your job to decide if someone's competent. How in the world can you remember that? Well, there's that catchphrase, competent to stand trial. If you've heard that enough on Law and Order, then maybe that'll help you keep this straight. So it's the judge who describes competency, and it's the physician who decides capacity. And some places they're in the habit of saying, well, the only person who can decide capacity is the psychiatrist. That's not true. Any physician can decide capacity. Ideally, it's the patient, it's the physician who's seen the patient the most, because you know what their baseline is. And it's a functional assessment, and it can change, and it may change fairly frequently depending on the patient's underlying health status. Obviously, if a patient's delirious, they've temporarily lost capacity. So the way to, you know, the thing in the back of your mind, or maybe that I've tried to put a check mark on myself for this, if you start having a conversation with a patient about risks and benefits of taking a medication, doing a procedure, and they're looking at you funny, and you're thinking, it doesn't matter how long I say this or how many ways I repeat this, this guy is not going to understand what I'm saying. If you feel like you cannot get there on informed consent, no matter how hard you try, then maybe this patient doesn't have capacity. Maybe that's why you feel like you can't get where you want to on informed consent. So what does Iowa say about capacity? It's the ability to understand the nature and effect of one's acts. It's a fluid concept, which I highlighted there, and it reflects a specific moment in time. You could have one physician, maybe you're a resident and you're working in a hospital, and you go in and assess your patient at 8:30 a.m., and you determine that he has capacity, and then the attending comes by and looks at him again at 11 and goes in and tells you you're an idiot and that he doesn't have capacity. Well, maybe you were both right. Maybe the capacity changed in that 3-hour window. Maybe there was an underlying clinical change. So lack of capacity means that you can't have informed consent. And if you can't have informed consent, you probably shouldn't be trying to do something that requires it. So because the only way to move forward at that point is implied consent rather than actual informed consent. And with implied consent, we're relying on emergencies. If somebody gets wheeled into your ER on a gurney and it was previously complaining of something that made you think they have a ruptured aortic aneurysm, then what are you doing? You're seeing if they have a DNR or pulse. And if they don't have that, you are assuming you have the ability to save this patient's life. You don't have informed consent. You can't even talk to them. You have implied consent to act and save their life. So of course, what we've talked about earlier is nailing down these things in advance to know when you do or don't have that implied consent, when you can't get informed consent. Does that make sense? So that's the best way I can kind of go over capacity using terms that we're maybe more familiar with.
Phil, so my question was, earlier in my career as a director, it became a problem for us. Do you have them sign this when they come in, a month into the system, or when do you do this?
I would like it to be part of our intake process. I think.
And why?
Why?
Yes.
Because you never know when somebody's going to have that heart attack or what they might want you to do. The longer you've seen the patient, the more likely they are to have some of these harder conversations. But ideally, I would like to have that when they first get here.
The other argument was that the patient may be coming into the prison for the first time, have several challenges, mental and other things coming in, and that fully being competent to really address these things, which are life-changing situations in a correctional setting.
Sure.
And so those were the arguments that we were battling with The lawyers want to take it this way. Physicians and medical group wanted to take it this way, and you find yourself as an administrator in the middle.
I guess that's a very good point. I guess what I would agree with you that people are certainly situationally depressed when they first get there, and they may answer these questions differently than they would 1 month, 5 months, 6 months, a year down the road. So I guess I'm going to annoy myself and annoy you and say we should do it at the beginning and we should revisit it in 3 months and in 6 months, because there's nothing that says you can't keep updating this as often as you like.
I agree with you.
Okay, so capacity options. You're going to make your own determination as a physician based on the patient's response to your questions. Focus on their aspects of informed consent. Are they understanding what you're saying? Okay. And there are some standardized tools. I don't necessarily use these, but we're going to go over some of them. And I would point out that there are times when the government, in the form of the FDA or some other group, they step in and they want to tell us exactly how to do a certain piece of informed consent because they think that maybe we're not going to do it well enough, or maybe it needs to be done in a really specific example. And one of them is the isotretinoin quiz and pledge that patients have to take before they take that, due to the birth defect risk and the tendency for female teenagers to use that medication, and young women. So, okay. So what about common capacity exams? What do those look like? Thorough mental status exam should include all the following. So what's the patient's overall appearance and behavior? Do they look disheveled? Do they look like they care about what's going on right now? Are they in a state of depression, as we were talking about a moment ago? Or maybe they're not going to give you opinions that are going to reflect their preferences long term. So this is there more as a reference. I don't know that we need to walk through each one of these. If you think the patient's delirious or having any kind of hallucinations, now is not the time to do this, obviously. Okay, this is an example of something that annoys me. So you have notice these words are accurate. I was careful with this slide. So these are formal capacity assessment tool options. So this is what we do. We judge capacity. The judge judges competence.
So it's called competence.
Yeah, which drives me nuts. So there is a MacArthur competence assessment tool, which is for judging capacity. How do you like that? So you've got that. You've got two others listed here that are also options. I don't really think these formalized tools are necessary, but if you want to dig into this, you can. So is decision-making capacity assessment triggered by a patient saying they want to do something against medical advice? Hopefully that wasn't what caused you to do it. Hopefully what caused you to do it was you couldn't get informed consent, and you were picking up on that as you were discussing things with the patient. If a patient doing something you don't want them to do is what triggered it, then you wonder about whether or not you're making the right call by trying to argue they don't have capacity when maybe they do, and they just have different priorities. I recall when I was a resident working in the ICU, there was an attending once who told me, I went back and relayed that a patient didn't want to do a particular procedure, and his response was, you need to talk to him longer, you need to scare him into it. And that's an interesting thing to say. You can read that two ways. One, I haven't done appropriate informed consent. Maybe I wasn't blunt enough. Or two, the attending isn't respecting the individual patient's decision. So we have to figure out where that is here and focus on those informed consent options rather than, the fact that something's AMA. All or nothing. So decisions can be nuanced, and if you do informed consent and you do it well, and you figure out what the patient's capacity is to make those decisions, then you can hopefully take into account their nuance and not force them into one size fits all box. If they have a lot of places, if you say you're DNR, then they want to make a lot of assumptions based on that. But you could be as specific as you want about those things. You could say, I don't want to be intubated, but you're able to do compressions, but I only want you to do compressions for so long, or I don't want this, that, or the other. You're allowed to be specific if you have thought through that amount. that amount of care. And of course, this capacity can change frequently. We've already talked about that. And no, you do not have to wait on a psychiatrist in order to have those conversations. Incompetency, there's an example cited for you here in Iowa, and that's your lack of ability to understand or discharge any healthcare decisions. And this is something that the court's going to declare. So capacity is something we worry about. Competency is something the court worries about. And the court isn't just thinking about healthcare. They might be thinking about finances or any number of other places that you can no longer address because you no longer have the mental ability to do that. And that's when you see people become a ward of the state for various reasons. Okay. And if you have a patient who's in an assisted living or nursing home setting, you got to worry about all these potential areas for mistreatment, and you got to do these, pay attention to these things. That's there for your reference. I'm going to speed up because we're running out of time here. So to highlight it a little more, the legal scrutiny, if you have an advanced directive, an actual advanced directive, that's going to take precedence over a MOLST or a POST, even if those things were written more recently. So if that exists, find it and fix it if it needs to be fixed so that it reflects the patient's wishes, or make sure the MOST or POST matches it. Okay.
So
Greg,
could we just go back to the addiction thing for a second? Because a lot of those guys don't have any proper executive thinking at all.
This
and
one?
a lot of issues.
Mm-hmm. Yeah, I agree. If you're in a state of addiction, then depending on what you're addicted to and how much you've taken, and whether or not you're in withdrawal or whether or not you're in a toxic state, then you're in delirium, and you are at least temporarily lacking capacity. And depending on how much that addiction has affected your overall mentation, you may ultimately lack competency and be deemed incompetent as well. The most classic example maybe being, somebody smoked marijuana for a few years, and at first it was no big deal, and now they're schizophrenic from their marijuana use, and now they lack not only capacity but also competency.
Yeah, thank you. Thanks, because we see it all the time. I mean, I wouldn't trust the judgment of a bunch of those folks until they're cleaned up a bit and are doing better, for sure.
Yep. Okay.
So I hear you. Yeah,
Okay.
I had a question. I hear you saying that having an advanced directive, something signed by a lawyer, is far superior than just having this piece of paper, this POST or MOST or whatever it is. And I can't but disagree with that, but agree with that, except, gosh, I don't think I've ever had a patient bring me a copy of his advanced directives signed by a lawyer to show me in all my years in doing corrections. And
Wow.
And where do you put it? And I mean, I'm looking maybe for a little bit of practical advice about what happens, what happens in the real world when because that seems like a much better idea to me, but I guess I never came up,
We try to keep a copy of it multiple places. The patient keeps the original. DOC usually has a copy somewhere, and then we'll try to make sure the nurses will scan a copy into the EMR.
So you have them bring it in
that it
and
doesn't have
scan
to
it
be
in.
signed by their attorney, but it does need to be notarized, at least in Wyoming.
Yeah, on disinterested parties, right? And so you actually have had that happen where somebody's brought that in and scanned it into the chart.
Mm-hmm.
Awesome. Okay.
Mm-hmm.
So the other people have a lot of that experience. That's much better than what I was doing.
What I wanted to do for a while, I see why people didn't like this, so I have since sort of backed off on the stance. But if they have that robust advanced directive, that's technically all you need. The challenge is not everybody has that or wants that. And you want to have some uniformity to what you're referencing quickly in the event of an emergency. And some people might write a lengthy advanced directive. There's no page limit, to those things. So to that end, that's why we still try to fill out the post as well, and we try to have it agree, because you want to have your quick reference document for the phone call of, this guy just fell over, are we coding him or not? Mhm.
Thanks,
Yeah,
that helps a lot.
I've only seen a few advanced directives in my career. In Tennessee, when we were still with, I'm not there anymore, but in Tennessee, we were doing paper charting, and the DOC did a real push to have everybody fill out their, makeshift advanced directives, and that was put on the front of the chart. And it was signed and be notarized there.
Well, good.
Any other questions, comments?
Mhm.
I am very much wanting to get your input into this. I think most
I
everybody
have a
has.
question.
Go ahead.
Hey, Dr. Carter?
Is there an age at which you start this process? Or are you also doing advanced directives on 19 and 20-year-olds?
Yeah, I will admit I don't have quite the motivation that I would for someone who's got multiple chronic conditions and is older, as I do for a younger patient, but my goal is to have this for everybody. And what I had when I first made that recommendation was, several nurses and folks at DOC said, well, we're not doing that for, a 19-year-old or a 30-year-old. We don't care if they want to be DNR, we're going to code them. And my answer was, you can't. I mean, I'm in the role I'm in right now. I'm a physician. I'm not their attorney, but I'm, as far as I know, if somebody says they're DNR and they happen to have a heart attack at 30, even though they didn't expect one, then that's their right to make that determination. Of course, they can't have a suicide attempt and they can't be assaulted, but if that's how they want to go, then that's their right to do that. So to your point, yeah, we need to do this. We need to have this discussion with everybody.
I think Dan has another question.
Yeah, hey, Phil, I kind of run all the inpatient hospitalization service in Georgia now. And one of the things that we run into all the time is our older patients. A lot of them haven't done the DNR or pulse, MOLS, anything like that. They're in the hospital. The hospital will call the family to make them comfort care, hospice, withdrawal care type of thing. And they still have, maybe a couple weeks left to live. They come back to us in our kind of hospital facility, and we may not have anything written, and so we're trying to call the family and so forth and get that documentation. Does what the hospital, documents not stand and cover us? Can it pass through?
Oh,
to
yeah.
us?
Yeah. If they filled out a MOLST or a PULST, number one, hopefully you have a state database you could pull it up in, even if they're too carefree to send it to you or fax it to you. But whatever the patient signed most recently, assuming they had the capacity.
This is in non-capacity. This is when they don't have capacity.
Well, then you're not talking about a MOLST.
Well, that's true. This is
Yeah.
more.
So this is multiple physicians saying they lack capacity and care is futile, and we discussed it with the family.
Mhm.
Okay.
Right.
Yeah. Then can you rely on that? I would think so, unless there's been a change in the patient's clinical status or mentation where you can, where you would document otherwise, you could still rely on that. But this is the worst case scenario that we don't want to have happen.
Right.
Yeah, this is exactly why we do all these things. So the hypothetical you've outlined, do you still have the right answer? Probably. Is the risk of litigation much higher if the family or the patient or somebody changes their mind along the way?
Mhm.
Yeah.
Yeah. Unless they can get something notarized from the family at the hospital.
Or, the more common scenario I see, I think, is, somebody doesn't fill this stuff out. And then they go to the hospital and they have the heart attack or whatever, and now their ejection fraction is 15 and they're kind of in and out of it. And you catch them on a good day and they fill out the PULST when physicians agree that they have capacity. There was no advanced directive. So you sort of have this PULST that was filled out in a window of time where they could make the decision. And now they're not really talking or anything. And maybe they wanted to do everything in that brief window. And now you've determined that care is futile. And that's sort of a worse hypothetical, but in some ways more common. So, Yeah, but you can avoid a lot of that with the advanced directive having being filled out, and then you've got the proxy decision maker that's solving all these problems for you because you're having the conversation with them.
Mhm. Thank you.
Well, thanks, Phil. That was awesome. I really appreciate it. I learned a lot, and I'll just remind everybody, get registered early for Salt Lake City, September 9th to 11th. And thanks again, Phil.